Hello everyone and welcome to the HiPP Showcase event for 2022. Thank you for attending. We have a fabulous registration number. Over 190 people have registered. So thank you very much for your support of the Centre of Research Excellence in Health in Preconception and Pregnancy. And I'm thrilled to be hosting the session today. What I'll do is I'll share my screen and get started with the brief overview that I have for today. So let me share my screen. Okay, and I'll just change the displays. I'm hoping that you can all see that. So I'd like to begin by acknowledging the traditional owners on the lands on which we all meet today. These lands always were and always will be Aboriginal land. I'm meeting on the lands of the Burwarang people of the Kulin Nations and pay my respects to elders past and present and acknowledge any Aboriginal people that are with us today, as well as our valued consumer representative, Louisa Wetham. Let me just, my apologies. Let me just move to the next slide. So you'll see that we have a fabulous agenda for you today that has keynote addresses, but also fabulous presentations from CRE HiPP affiliates. So I won't go into those in detail now because I will do so when I introduce each of the speakers. The CRE team HiPP is obviously a collaboration. It can never be just one person. I am Helen Skatiris, for those of you who have not met me or who do not know me, and I have the privilege of being the Chief Investigator A, the lead investigator and the director of CRE HiPP. But as you can see there, we have 10 chief investigators from all around the country, and we have 10 associate investigators from all around the country. And we also have consumer and community involvement, very valued component of our CRE, and of course, early and mid-career researchers and PhD students. CRE in Health in Preconception and Pregnancy aims to refine and implement health promotion, lifestyle improvement and obesity prevention, strategically targeting women preconception and during pregnancy to improve the health of women and the next generation. For those of you who aren't familiar with Centres of Research Excellence, they follow very key criteria across generating new knowledge, translating that new knowledge into policy and practice, developing a multidisciplinary research workforce, and leveraging extensive existing multidisciplinary collaborations. Again, it just shows you the breadth of a Centre of Research Excellence. And so, of course, our remit is improving health in preconception and pregnancy across all of those criteria. But I've sort of said this repeatedly, we can't do it alone, and I'm really proud that the Centre of Research Excellence has established several robust and consolidated alliances. The first that you can see there is the Australian Anti-Racism in Perinatal Practice Alliance that is led by Dr. Jacinta Cracker, who is an Aboriginal woman, and Rochelle Hine, Dr. Rochelle Hine, a colleague. They're both colleagues of mine at Monash University. Really important that we consider racism. We cannot improve the health of women in preconception and pregnancy if we do not redress and reverse racism that is apparent. The other alliance is Growing Queer Families Alliance, and we established that in 2021 to ensure that CRE HiPP is inclusive of all women and people who experience pregnancy. And that came again through our consumer involvement and discussions. I'm very proud of that alliance. We actually have a special edition coming out in midwifery in July next year. The Preconception Health Network, which is led by Associate Professor Jackie Boyle, who is a Chief Investigator on CRE HiPP, and also Professor Kirsten Black, who is a Chief Investigator on CRE Sphere. And that was set up to promote best practice in preconception health promotion and care. And as a Centre of Research Excellence, we are part of the Collaboration for Enhanced Research Impact CRE that is led, a joint initiative between the Prevention Centre and other CREs across the country that are focused on prevention. It's fabulous to be part of that. So I've highlighted there the multidisciplinary research workforce, because for me, the most exciting part of leading a Centre of Research Excellence is building capacity in our early career researchers. And so I want to take the time to walk you through some of the achievements that we have had in that area. So when we first started, there were 3 early career researchers named in the actual application that was successful. Now we have over 160 early career researchers that are associated with CRE HiPP and more than 25 PhDs. And that's just in literally 2 years. So you can see how important the CRE is for building that future workforce. One of the early career researchers is Dr. Bryony Hill, who also will be presenting today. And this is just a quick snapshot. Please don't try and read this figure, but it just shows you how Bryony has been able to leverage her existing NHMRC early career fellowship. She was then fortunate enough to work on CRE HiPP, then able to obtain her own lead CIA ARC discovery, and just in the last round was awarded an ARC DECRA. And Bryony is focused and pioneering weight stigma in the reproductive years. Dr. Cherise Harrison was successful with a Medical Research Future Fund grant of 1.4 million. She's focused on optimising the delivery of antenatal interventions in public health care and to improve equity, access and engagement for better maternal and neonatal health outcomes. And her MRFF builds on the CRE work that Cherise is leading in pregnancy as a mid-career researcher now, because Cherise is a senior researcher fellow, and that's all about evidence-informed lifestyle programs to enhance skills in self-management and behaviour change to achieve optimal levels of health through preconception, pregnancy and postpartum. The other early career researcher who was named on our application is Dr. Sue Lim, and Sue has achieved just as much by being awarded a Monash Institute of Medical Engineering grant, innovative methodologies in AI-powered risk prediction and risk communication in pregnancy, and also a Heart Foundation Vanguard in the recent round to reduce heart disease and diabetes risk in women who had gestational diabetes. So you can see there how much they have achieved, and we're very, very proud of them. We're also very proud of early career researchers who are now affiliated with CRE HiPP who weren't on the application. This is an example of a practicing health professional capacity building awardee, Dr. Zoe Bradfield, who is working on the MidPIC study, midwives provision of preconception and interconception care, improving sexual and reproductive health in Australia, and she's working with chief investigators from CRE HiPP. This is also an early career researcher mentoring program that has awarded these 5 amazing early career researchers funding to be able to come together and receive the mentoring they need to do work that they would normally not be doing. So this has brought them together. They are working on a high impact, hopefully, paper around sharing the mother load, and they're doing a review and developing a conceptual model to strengthen the narrative for enhancing fathers' participation in early childhood obesity. We also offer PhD support awards, and very proud that this year we were able to support 7 students across the country to be able to either go to a conference or to publish their work in open access. We know there are so many barriers to early career researchers, and anything that we can do to support them in this area will mean that we will have a better research workforce that's equipped to take over. The same with our early and mid-career researcher collaborative awards. Very proud that we also have awarded there, you can see 6 early and mid-career research awards this year. We also awarded some last year. And these are larger grants, so they'll be able to do more work with the funding. It is seed funding, but again, it gives them the opportunity to collaborate with other researchers that they might not necessarily have been collaborating with, and to get on with their research when we know Category 1 funding is really, really difficult to obtain. So they're all very, very grateful, and they're doing amazing projects. You know, we're just so excited to see how their work is really strengthening our own Centre of Research Excellence. And finally, one of the things that makes me most proud is the Health in Preconception, Pregnancy and Postpartum Early and Mid Researcher Collective. And that was established at the outset of the CRE. It was established by Dr. Bryony Hill, and we had, I think, 20 members when it was first established. We now have over 160 members in that collective. This is a conference that they run every year now. It's become a resounding success. It's amazing to see them all gather and disseminate and share their knowledge, their networking. They have strategic goals. They have so many people volunteering on committees that it's just amazing to watch. So I'm very proud of this, and it's probably one of the highlights of the CRE. But as you can see, all of those early career researcher achievements have been fabulous. So that's my presentation. I'm just going to stop sharing. So thank you very much for seeing that. I'm just going to check if Nisha is on the line, because we were having some difficulties joining. If not, we will hand over to Bryony Hill.
Nisha's on as a not on yet, Helen.
Okay, great. So we will move. Sorry, we're just going to reverse the agenda just for this one. Hopefully Nisha will be able to join, and it's not her fault. It's technology. So I have great pleasure in introducing Dr. Bryony Hill. I've already mentioned Bryony is an early career researcher, part of CRE HiPP. And Bryony will be talking to us today about developing a set of core indicators for preconception health in Australia. So over to you, Bryony.
Thank you so much, Helen. And seeing that recap of all the achievements of CRE HiPP that you just highlighted, it's quite a privilege to be part of that. So today I'm talking about some work from the Preconception Health Network that Helen mentioned earlier. So I'm Bryony Hill. I'm in the Health and Social Care Unit with Helen at Monash University. And this presentation is around a project from the Preconception Health Network that's focused on developing a set of core indicators for preconception health in Australia. So who are the Preconception Health Network? So they're a network that's nationally a national cross-sectional network who aim to promote best practice in preconception health promotion and healthcare. And we aim to empower all people to optimise their reproductive health and wellbeing across the lab course. And so usually when you talk to someone and ask them, what does preconception mean to you, that they typically think about someone who's planning a pregnancy. But we take a life course approach, meaning that preconception health is important for everybody all the time. And so we aim to support people for healthy pregnancies and healthy children across the life course. We acknowledge that there are broader socio-ecological and environmental contributions to health and wellness, and we aim to ensure that there is broad representation among the network. So it's not just a bunch of researchers and clinicians, but we're also privileging the voice of consumers in our network. So the network is led by Associate Professor Jackie Boyle and Professor Kirsten Black. Alongside, we have Edwina Dorney and then myself as the coordinator of the network this year. And if you want to learn more about it, you can check out the website on the CRE HiPP website. So the Preconception Health Network collaboratively generated some key objectives. And these were to identify and prioritise gaps in preconception health promotion, care and research in Australia, foster collaboration across healthcare so that people are receiving consistent messages and continuity of care. So we recognise that healthcare doesn't start in the healthcare sector, but that our wellbeing is generated across not only the life course, but across society. So for this reason, we foster collaboration across health sectors, including healthcare research, social care, education, government policy, so that women can have the access they need to knowledge and resources to enable them to optimise their decision-making. We advocate for systems change and for legislation and policy change to promote preconception health, and also, of course, promote the translation and development of evidence-based resources. So the work we're doing is not just sitting there, but we hope that it can actually inform change so that we can have, optimization of the population health moving forward. So this project was one of the key goals that were identified by the Preconception Health Network, and its aim is to develop a framework to identify a set of core indicators for preconception health in Australia. And we also hope to identify data sources that align with the core indicators, and also to look at that from the flip side, where don't we have data, and what data do we need that we don't have? So being able to develop a framework to identify and measure preconception health in Australia will help us develop report cards to monitor indicators over time. It will help us feed back to policy and practice on things like health policy, health promotion and service initiatives. So is that service working? Do we need to make changes? And then finally, it will help us facilitate monitoring of preventive health efforts on a local, regional and national level. So this project began with 2 workshops, and the first was around identifying the key conceptual framework that was going to underpin the work moving forward. And then we aimed to define and prioritise the preconception health indicators and what we were going to do next. And so the first workshop was a Zoom workshop. We had a facilitated discussion by an external facilitator, and we had attendance in the room from clinical researcher and community representation. And I think there were 19 attendees to this workshop. And so the focus of the workshop was around our conceptual framework to guide the core indicators project moving forward. So in the postcard to the left of the screen, you can see what were the key things that we discussed. So that triangle there represents the preconception population, starting from the intentional or pregnancy planner population at the top of the pyramid, where someone has a conscious decision to conceive, all the way down to the bottom of the pyramid, recognising the life course perspective to preconception health. Preconception health is important for everybody at all times. We also looked at a socio-ecological model, and so that refers to how a person is at the centre of a model, but it recognises that there are a bunch of socio-ecological environmental contributions to well-being, including things like our family, home interaction with others, the community, government, and culture and society. We discussed what populations should be included when we're looking at preconception core indicators, and how we're going to frame indicators to make them manageable. And so as a collective, we discussed and came up with the following key points that would guide the work moving forward. And that was to take a life course and population health approach to preconception, to include people who are planning pregnancy, as well as those who have unplanned pregnancy, including both men, women, with and without children, and explicitly people who are less than 18 years old. And the reason we've done that is because, as I mentioned, we typically think of preconception as being women planning pregnancy, and we need to move on from that narrative and ensure that we don't neglect other populations. All genders are included, people from all backgrounds, including all socio-demographic, cultural, linguistic, and geographic backgrounds, and indicators that are relevant across the socio-ecological spectrum, right from individual related indicators such as individual behaviours, all the way up to those broader social determinants of health. And we categorised indicators into domains or groups of similar indicators that go together, such as things related to healthcare or things related to reproductive health. So the second workshop was where we got our hands dirty, and this was a full-day in-person workshop attended by clinicians, researchers, and policy experts. You can see at the bottom, I've included some of the organisations that were represented in the room, including Healthy Male, the Australian Women's Health Network, and MacKillop Family Services. We ran a pre-workshop Delphi survey to evaluate people's priorities on what were the core indicators and domains that they thought were most important. And then we had a plan for the workshop to rank the indicators in terms of importance, come up with a consensus and decide next steps. But this workshop was a really good example of how to pivot and think on the fly. And thanks to the wonderful brains in the room, we were able to switch up how we did things and come up with an even better plan moving forward. And so the group decided that it was too hard to rank the indicators because all indicators are important, and sometimes some things are more important depending on the context that you're working in, whereas other times other indicators or domains are more important. So instead, we decided to come up with this framework. And so at the top, we have equity and we have social determinants of health, and these domains are relevant all the time. We cannot forget them, we cannot neglect them, and they underpin everything that we do when we're thinking about preconception health. And then we came up with 6 domains that capture areas of preconception health that are important. And these are reproductive life planning, healthcare, clinical indicators, nutrition and physical activity, mental and emotional health, including our safety, quality of life and well-being, and of course, prevention. So these are not mutually exclusive, and the importance of each might change depending on the needs of the population that you are looking at the time, or the recipients of the goal that you are trying to do. For example, if you're trying to change policy, if you're trying to change healthcare. And so the next thing that the group did was to come up with a bunch of needs. What are the needs moving forward? And we grouped these into health and social care needs, policy needs, and consumer or community needs. And so on the day we didn't have attendance of consumer and community involvement representatives because they are going to be running their own separate workshop where they have the space to share their views. And so these are just a couple of the examples of the needs that the group identified moving forward, but you can see there are some synergies across, for example, reducing silos between different care and communicating digitally across different sectors, incorporating things like MBS items for reproductive life planning so that we can improve primary care for preconception, as well as understanding that there is a diversity of healthcare practitioners that are involved in preconception care, such as nurses, pharmacists, people working in social care, teachers, and prevention and sustainable funding are, of course, incredibly important. So these are the, if we had a wish list of everything we could do, these would be on it. And so the next step is to run our workshop for the consumers to get their input into the domains that we identified and what the priorities for their needs are. And then what are we going to do with that information? We hope to develop a preconception report card to identify what is the status of preconception health in Australia. And we hope to use a data set such as the maternity information matrix, which is maternity services data. We understand that this excludes populations that are not women who are currently pregnant, but it's data that's available now and relatively straightforward to access. So it's a starting point, it's that low-hanging fruit. And then we're going to expand our evaluation of the data that we have to inform indicator monitoring at a population. So that's a nice big goal of the network moving forward. And so I just would like to finish up by thanking the team. In this preconception core indicator project, we also, along with the Preconception Health Network core team, had input from Professor Danielle Matzer, Dr. Karen Hammerberg, and Ms. Haymanot Halu. And if you want to reach out, you can do via our email. Thank you very much.
Well done. Thank you so much, Bryony. I forgot to tell our audience the best part of this is that you can ask questions of the presenters and there's a Q&A box. So please do add any questions that you might have and I can read them out. Bryony, we've got time for maybe, one question. So I'm going to ask it. I was just wondering, because I have, a real interest in social care and in joined up, initiatives across health and social care. What is the Preconception Health Network doing to reach women much more broadly and not just from a sort of a medical health perspective?
Yeah, great question, Helen. And so we've purposefully and strategically expanded our network to make sure that we are inviting representatives from social care to join the network and to join the activities. And we did have Killet Family Services represented in the room at that main workshop. And so that's just, we're very strategic in terms of making sure that we're not excluding particular groups that might have additional needs so that their voices can be heard.
Fantastic. Well, thank you very much. Thank you, Bryony. And I know you're presenting on behalf of a very large team. It's an amazing initiative in Australia, obviously very much needed. So it's a proud linkage to CRE HiPP. Thank you so much, Bryony. Okay, and now I have much pleasure in presenting our first keynote speaker, Dr. Nisha Knott, who is an obstetrician and current Clinical Director of Obstetrics and Gynecology at Peninsula Health. Nisha was trained in India and the UK before moving to Australia in 2010. She's currently a RANZCOG board director and is passionate about health equity and promoting diversity in health leadership. And I can't tell you how excited we all are at CRE HiPP to have you with us, Nisha. Thank you so much for being our keynote today. I am going to be sharing Nisha's slides, and so I will start sharing my screen now.
Very much, Helen, and all of the team at CRE for having me. I am clearly very challenged technologically, and so I need you to help me with this.
Of course, that's not a problem at all. Really, really happy to do it. I'm just going to, can everybody see that?
Yes.
Yep, full screen. Okay, over to you, Nisha.
Lovely. Helen, can I just get you to come out of full screen so that I can
Oh
see?
my goodness, yes.
No,
my
just
apologies. I haven't started on the first slide. That's a really boo-boo. Sorry. It's a bit naughty of me.
Not a problem at all. Let me start by calling the traditional owners of the lands on which all of us are currently based and recognizing that First Nations women have been birthing on this land for many, many thousands of years, and we are all on unceded land. I also want to acknowledge something else, and I want to acknowledge that there is an elephant in this virtual room for us. And I want to be upfront by saying that what I'm going to talk about, what I'm going to present to you today is not going to sit comfortably with many of us. And indeed, it should not sit comfortably with any of us, because this is about recognizing where our blind spots are and trying to address them as best as we can. And we can only do that by recognizing them and acknowledging them and moving on with them. Of course, we all have a view of ourselves, and that view is that we are basically very fair people. We judge others on merit. We, of course, don't have any biases, because that's how we view ourselves. And it's very important for us to view ourselves like that, because otherwise we wouldn't be able to function if we thought of ourselves as being bad people. But it's not true about me. It's not true about 99.99% of people, because all of us have biases within ourselves, and we have to acknowledge those biases, and we have to recognize that we can't see the privilege we have. Only people who don't have that privilege can see it and recognize it for what it is. I can see my lack of privilege because I'm a woman of color, but I can't sometimes see what privilege I have with being somebody who can speak in English, somebody who has a platform to use. And so that, to me, is me checking my own privilege. And before we move on to the next slide, I want all of us in this virtual room to take a moment, check our own privilege, and we will all have at least one thing that we can say is a privilege before we move on. So having done that, here's a scenario. This is a healthcare organization, probably one that any of us could be working at. It's signed up to the gender equity target because that is, probably in Victoria it's mandated, so they didn't have a choice. They had to sign up, but in many other places they wanted to do the right thing and so have signed up. And they advertise a job. For argument's sake, I have said this is a job of leadership in safety and quality. They have two candidates who apply, candidate X and candidate Y, and those are their CVs. Now, if I said to you that candidate X is female and candidate Y is male, and that the job was given to candidate Y, we would all recognize that is a function of how gender inequity works. And we would all recognize that that's unfair. It probably came down to the interview where candidate Y was very confident, whereas candidate X, although she had all of these qualifications, was probably suffering from imposter syndrome, didn't present herself well at interview. We have all these tropes about men versus women. If I were to say to you that both candidate X and Y are women, and I'm using men and women as default, we all recognize that that binary does not always apply, but as a default for us to understand, I'm saying these are both women. The difference is that candidate X is a woman of color and candidate Y is not a woman of color. And if I were to say to you that the job went to candidate Y, that's a whole different feeling, isn't it? Because it makes us all feel slightly uncomfortable, because the organization said, yes, we've ticked the gender equity box because we have given the job to a woman. We have a woman leader amongst us. But did they actually give the job to the right woman? And that's when we start having this kind of discomfort with some of the decisions we see around us. And we should be uncomfortable. Like I said, I'm not going to make you feel warm and fuzzy. I'm sorry. So we'll move on to the next slide, because does all of this really matter? Now, this is a report from business. This is a McKinsey report, and it's looking at businesses, and it is titled Delivering Through Diversity. And there are 2 points in time. There's a 2014 report and a 2017 report. And what does it show? So on the next slide, it shows that diversity does matter. Of course, it does matter. How can it not? There is a relationship within business between diverse teams who perform better. Diverse teams with diverse leadership perform better. And it's not just gender, it is diversity beyond gender, looking at age, generation, ethnicity, international experience. There is such a wide, when we talk about diversity, we can't limit ourselves to one thing, because the whole point of diversity is to include all of those different things that bring different perspectives. And very importantly, this report finds that there is a penalty for opting out, that if we don't promote diversity in all its various forms, there is a penalty to be paid. We don't do as well. So this is about business, but does it matter in healthcare? Surely individuals choose to go into healthcare because they want to make a difference, especially they want to make a difference to where it matters most. So surely in healthcare, we must be better. Let's look at the next slide. What does that show us? Now, I've just listed some of the facts. These are all backed up by research, and by no means is this an exhaustive list of research into evidence that shows that actually diversity does matter. We know that these are, quite a few of them are very famous studies. The very most famous one was the one that showed that mortality among Black newborn babies was halved if their treating doctor was also a Black doctor. Now, that also sits uncomfortably with us because all of us go to work going, you know what, I'm treating everyone the way I would treat anyone. I am not going to treat people differently based on whatever they are. But the research shows that all of us do it. So what do we do about it? All of this data is from America. What about our own country? What about Australia? Let's look at what happens to our own population. So if we're talking about preconception, and so smoking during pregnancy is obviously correlated with smoking pre-pregnancy, and we can see it. These are just statistics from Victoria, a very small state in a very large country that collects data every year. And this is the latest data from 2020, which shows that smoking rates among Aboriginal women were much higher during pregnancy, and so must have been much higher pre-pregnancy as well. Looking at other statistics, if we move on to the next slide, we'll see that Aboriginal women are more likely to have smaller babies. They're more likely to have preterm babies. Moving on, we know that they're more likely to have what's called severe acute maternal morbidity. So although they are only 1.5% of women giving birth, among the women who have a serious morbidity, they are 3.6%. So is that just a gap between Aboriginal and non-Aboriginal people? Is that the only gap we have? Well, data shows us that actually that gap is there for other people as well. So if we look at perinatal mortality on the next slide, we'll see that there is a stark difference between perinatal mortality amongst those who were born in some parts of the world versus those who were born in some other parts of the world, which is what the next slide shows. It shows that the difference between that mortality is about 3 times. So 4.6 for mothers who were born in Northwestern Europe versus 12.4 for mothers who come from North Africa and the Middle East. And if there's anything that COVID has shown us, there are quite a few silver linings from COVID. Some of them are not silver linings. And one of those is the fact that mortality rates among migrant communities were so much higher than mortality rates among non-migrant communities. So there is a gap, and there are many gaps. So is leadership really the answer? Can we make a link? Again, looking at American leadership, we can see that we have barely 14% of hospital board members that come from ethnically minority groups in America, 11% of executive leadership positions, and only 19% of first and mid-level managers. What about Australia? We've got some really good data right here from Monash about women in leadership. We know that 75% of the healthcare workforce is women, but only 38% are actually at that chief medical officer or at a executive leadership level. What about other diversities? We know that First Nations people are about 3% of our population, but barely 0.5% of the medical workforce, 1% perhaps of the midwifery workforce. And we don't know what sort of ethnic diversity there is within our leadership. And we can't change what we don't measure. That, if we don't even look at it, then we're never going to be able to change it, or we're never going to be able to put into place some measures that will actually work. So is this problematic? We'll go on to the next slide. In my point of view, and I think most people will agree because this is very well known, that healthcare is delivered by women, led by men. And if we add another layer to it, it is delivered predominantly by women of color and led predominantly by white men. And that to me is something that we have to recognize. and we have to try and fix. So what do we do about it? Moving on to our next slide. Yeah, why should we even bother? We should bother because actually it is people who lack privilege who prioritize making sure that that privilege or that lack of privilege is addressed. Not only that, a diverse leadership sends a powerful message to the patients and the clients that we see who come from very multicultural backgrounds that we all matter equally. And at risk of sounding like a broken record, it's not just gender. So what do we do? Having a policy isn't enough. Having a policy is a good start, but it isn't enough because we know that just by having diversity doesn't mean that we create a just culture and an inclusive culture. Because although we may have the one person who represents diversity, does that person have a voice? Do we actually know what our blind spots are and what are our stereotypes for traits of leaders? Again, we go back to the leadership styles we have seen through the pandemic, and we've seen so many different leadership styles and some that are very non-traditional, but very effective. So accepting that there might be non-stereotypical traits of leaders is really, really important. Moving on to the next slide. If we apply the same principle to everyone, we are definitely not going to help everyone succeed. And if we make it a tokenistic exercise, we are definitely not going to succeed. So what is equity? This next slide to me demonstrates equity, diversity, inclusion really well. And it has shoes, and I'm partial to shoes, so I quite like it. But I'm going to leave you with a back of envelope exercise. I want you to think about your team, and it might be just your small team, it might be a big team, and think about who are the people in your team and who are the people at the table. Because as the next slide shows, if you are not at the table, you are on the menu. So I want you to think about who's at your table, who's on your menu, and what's the one thing that you're going to do to change that starting today when you go back to work at the end of this webinar, or tomorrow when you go into work for tomorrow's shift. Thank you.
Thank you so much, Nisha. My goodness, I think all of us online will know and appreciate everything that you have said. But thank you for highlighting the importance, because as you said, we are still doing it. And there's no excuse for it still happening. And the more that we call it out, the more that we hear from esteemed people like yourself who know firsthand that it's happening, the more that we need to be able to reverse that and have, gender equity in the true sense of gender equity. Let me see if we have questions. So this is just a lovely comment to you, Nisha, to say that thank you very much for leading us through the hard conversation. So that's terrific. Thank you. I agree, because it is often avoided, isn't it? We don't want to have those hard conversations, but we should.
Absolutely.
So,
often people of color who avoid having that conversation because we feel uncomfortable bringing up issues as much as anybody else. So, for people here, I want everybody to realize that this is uncomfortable for all of us. It doesn't matter where we come from. It doesn't matter what our experiences are. We are all uncomfortable with it.
Yeah, absolutely. Absolutely. Please add questions. They're coming through now. Nisha, we do have time for questions. So please, while we've got Nisha, so precious, your time. Thank you very much. We should ask questions and seek some discussion around this. You do have another comment. This person's PhD is in the maternity experience of women seeking asylum in Australia, and it's so hard to get any data on this cohort. I agree that we can't change what we don't measure, and that's such a good comment, Glenys, who has left that comment. It's so true. We actually ignore these people. It's like they don't exist in our society, and yet we now have tipped over 50%. Our country is now 50% multicultural, you know, and yet we tend to ignore them. Nisha, do you have a comment about women seeking asylum and those groups that we just don't measure outcomes on?
I mean, not just not measure outcomes. How many research projects do we do where we explicitly exclude people who don't speak English? Because it's just too difficult to do research with people who don't speak English. But that means that we are excluding a large proportion of Australian people.
Right.
So we have to think about how we do this to make sure that we represent the diversity of the world we live in and the country we live in.
Yeah, absolutely. And there's a question here about, you know, what would be your advice to women of colour or of ethnic minority who feel that they are being discriminated against? You know, how do you broach that conversation?
There's no...
You know, how do you bring it up with your manager if you are in a more junior role? I'm sort of elaborating on the question, but I'm assuming that's what they meant. Yeah.
Yes, there is no easy way of doing it. I'll be honest and say that, you know, I have struggled with doing it myself in situations where I have found that I have needed to have this conversation. And my few kind of tips on how to do it is to have a tribe, have a group of people whom you can bounce ideas off and whom you can go to for advice on how to have those difficult conversations, because they're all going to be different based on where we are and what the situation is. And the other thing is sometimes it's wiser to walk away. There are other opportunities.
Really great advice. I was actually giving a talk yesterday on, you know, maternity issues in Hong Kong. And I said exactly that, Nisha. We really do need to create our tribes. You know, we need to have our support networks around us. And then if we have these difficult scenarios, often when you workshop them with people that you really trust, you can come up with good ways of solving them. So thank you. We have a question here about how do we support people from diverse backgrounds to be ready for and take on leadership without burdening them as the token person? Because often, you know, we do turn to ethnic minority, Aboriginal and Torres Strait Islander people, and we're pulling them left, right and centre. So, you know, on the one hand, we ignore them, and then on the other hand, they're over-researched. They're constantly being pulled in, which is awful. So what advice would you have around that?
I think we need to have a purposeful way of doing this, of actually creating the ability for people to get to this place where they can represent. So it shouldn't always be just a few select people, but actually having a pipeline through which people can develop those abilities so that there are more of us who can be representative. And also remember, like I said, I speak English. I have a platform. I by no means represent the asylum seeker woman who does not speak English. So it's just, you know, we can't expect one person to speak for the entire community. That's really important. But secondly, we have to have purposeful building of capacity.
Yeah, it's such a good point, isn't it? Another question here. Sorry, Nisha, you're very popular. Should we have transparent reporting on diversity in healthcare and leadership?
Absolutely. I 100% support reporting of diversity. To a degree, I also support reporting of what we actually pay people. Because if you look at the research shows that women are often paid less for the same work that is done by women, and people of color are often paid less for the same work done by white people. And so having transparency around this is the job and this is what you get paid and these are the people we employ will help everyone.
Yeah, I agree totally. And a sort of a similar question around that. How could we influence the political will to actually start collecting these data? Because, you know, it takes a lot of advocacy, doesn't it?
It does. And the more of us who do this advocacy, the more likely we are to be heard. So forming a coalition, speaking with one voice, speaking all the time and banging on about it like I am doing.
That's right. And we will join you. Another question, what are some practical approaches, things those of us at junior levels can do in our workplace to champion diversity? So very similar to the one before as well, you know. Is there anything else that more junior people can do?
So the simple thing you can do within a team meeting, for example, you're a group of medical students, you're a group of midwives, graduate midwives, whatever. You will have people from various diversity within that group, and allowing people to have the opportunity to speak is really, really powerful, because it gives a message to the entire team that everyone is valued, every opinion is valued, and everybody has the opportunity to voice that opinion. It's a very simple thing of purposefully saying to every team member that, you know, we're having this meeting, we're discussing whatever, our induction of labor rate, for example, and I want to hear everyone's view, which means that you're not singling out the person, because often people don't want to speak, they're afraid of speaking, but you're actually being inclusive and saying, I want to hear, or we want to hear everybody's views. That is a small little thing, but it can make a huge difference to people feeling like they're being heard, like they belong, like they're being included.
Yeah, really, really good advice. And so a few lovely comments, Nisha. Not a question. As a person of colour working in allied health, I found this to be such a validating and inspiring talk. Thank you, Nisha. And also brilliant. Thank you so much, Nisha. And there was one more that I saw there. Just I think another thanks, Nisha. So I've screenshot those and I will send them to you. I think I speak on behalf of everyone in thanking you so much for your wisdom and your very powerful presentation. I've just got another comment there to say it was really powerful, and it was. I feel like, as you say, Nisha, if we don't continue to have these difficult conversations, nothing will change. We have to rock the boat. And sometimes it also means that maybe, you know, some people fall out of love with us, but it doesn't matter, because if you're doing it for the best outcomes for all, then hopefully in the future we will look back and say, gosh, we remember the times where people were discriminated against, and hopefully, you know, that does happen in our lifetime. You know, I'm getting on in age, so I'm really hoping that we do see a change, because it is very slow. But thank you, Nisha. Thank you so much for your time, and congratulations on what you're advocating for.
Thank you.
Thank you very much. Okay. We can say goodbye to Nisha, and then that means that we will move on to the next speaker, who is Rebecca Maddell. And I'm really so pleased to be introducing Rebecca Maddell to you all. Rebecca is a PhD student, sorry, my apologies, a PhD student at the Monash Centre for Health Research and Implementation Science, MICRE. Rebecca is working with Dr. Cherise Harrison and Professor Helena Teed, and they're all affiliated with CRE HiPP. Rebecca comes to us with a lot of experience prior to her PhD. So we're really privileged today to have Rebecca speak to us about establishing consumer and community involvement, CCI group, to understand health information seeking behaviours for culturally and linguistically diverse women during pregnancy. Thank you so much, Rebecca. Over to you.
Thanks, Helen, and thank you for that very warm introduction. So I'd like to begin my talk by acknowledging the Wurundjeri people of the Kulin Nation as the custodians of the land on which we live, learn and work, and I respect their elders past and present, and will work as one community for the benefit of all. As Helen said, my talk today is looking at establishing a culturally and linguistically diverse consumer and community involvement group during pregnancy. So, as Helen also introduced, I am a first-year PhD candidate at the Monash Centre for Health Research and Implementation. I started my PhD in July this year. Aside from that, I also work with the Women's Health Research Translation and Impact Network, and I work as the Consumer and Community Involvement Project Manager. So while my talk today will largely draw on work from my PhD, I will also make reference to my work with the Women's Health Research Network. The title of my PhD at this stage is Optimising the Delivery of Digital Health Information in Culturally and Linguistically Diverse Pregnant Women, Improving Equity, Access and Engagement. Oops, sorry. Just a brief outline of my presentation. I'll give you a little bit of background around the research, what CCI is and why it's important. And then I'm going to talk to you about a couple of focus groups we ran with women from culturally and linguistically diverse backgrounds and how I then formed a CCI group from this and some key considerations. So my research aim is to support healthy lifestyle interventions for women during pregnancy who are from culturally and linguistically diverse backgrounds. For this research, culturally and linguistically diverse is defined as those born in a non-English speaking country and or those who do not speak English at home. This research is based in the Monash Health catchment, where approximately 2/3 of the population are non-Australian born. Previous research has shown that culturally and linguistically diverse populations can be at risk of adverse lifestyle behaviours during pregnancy, and this can have consequences such as excess gestational weight gain and can include complications such as gestational diabetes mellitus. So therefore, I aim to explore the potential for digital health technology, how to support and how this can support healthy lifestyle during pregnancy. So just a little bit about what's CCI and why it is important. So in 2012, the Australian Commission on Safety and Quality in Healthcare identified that consumers are really important and vital in health and medical research. We know that consumers make research relevant, meaningful, and more useful. So CCI involves having members from the community to participate in research activities. And there are a number of ways in which consumers can be involved in research. Some examples are consumers can be involved in committees and advisory panels. They can provide strategic advice for our research. They can review our documents and also co-design workshops. This list is far from exhaustive, and there are many, many ways in which consumers can be involved in our research. So from my work with the Australian Women's Health Network, consumer advisors bring different levels of experience. So we have some consumer advisors, or nearly all of our consumer advisors will have a lived experience, and they always bring that to the table and able to share their story. Most of our consumer advisors also have a connection to their community. So when they're providing feedback about our research, they're not just bringing their own voice, they're also bringing their community voice as well. And many of our consumer advisors also have a really good knowledge of the healthcare system and the implications for this. So therefore, we know that consumers help shape our research and healthcare needs, and this can lead to improved health outcomes. So I'm going to walk you through now the focus groups that we ran in October, and then how we then formed a CCI group from this. So in October, we ran 2 focus groups. They were 3 hours each, they were online, and we had 9 women in each focus group, and women were from a number of different cultural backgrounds. So the aim of the focus groups was to explore key themes about health, pregnancy and cultural considerations, and also to build rapport and develop ongoing relationships. And of course, all of our participants were remunerated for their time. So the first step of identifying and inviting people to our workshop was to connect with a number of community organisations. I'm very fortunate that in my current work with the Australian Women's Health Network, I already had a number of community and consumer connections, and they certainly helped me advertise the focus groups through their community connections. My supervisor also had a number of connections at local community groups, and she was able to act as a gatekeeper to be able to have an initial conversation with some of these community groups and tell them a little bit more about my project. So nearly all of these organisations here were represented during our focus groups, which was absolutely wonderful. I've also got a question mark down the bottom because there were some women who joined our focus groups and they found out about it through a friend or through a WhatsApp group. And it just shows you there's a lot of connections out there and there's a lot of support amongst women, which is amazing. So a brief snapshot of who was in our focus group. So as I said, we had 18 women in our focus group. We had women from Libya, from Sudan, from Iraq, from Dubai, from India, from China, from Myanmar, from Indonesia, and from Australia, who identified as being Vietnamese. Our women were aged between 31 to 47. They'd been in Australia for approximately 7.5 years. From these 18 different women, the 24 different languages were spoken. We had 3 women which were currently pregnant, 3 women with 1 child, 11 women with 2 children, and 4 women with 3 children. So just some high-level findings from our focus group as the analysis is still in process. But when we asked women what was important to them in pregnancy care in Australia, being supported and feeling understood were some of the main themes that came out. This quote here from one of our participants was, "She held my hand the whole time." And this is referring to a midwife who held this lady's hand throughout the whole time during her labour and how she just felt so supported during that experience. We also talked a lot about a number of cultural considerations, which was really interesting. And I really like this quote here from one of my participants who said, "It's hard to ignore something you've been told your whole life." And this is something I'm certainly going to bring forward into my research as it develops. So, selecting a CCI group. Thinking about our consumer advisors and the mix that we could have, people with a lived experience, community connection and knowledge of the healthcare system. And people who were in our focus group certainly had a mix of all of those. After the focus group, I rang all of our participants and invited them to be involved to form a CCI advisory group. And all of them said yes, which is absolutely wonderful. In saying that, this project is expected to run for 2 to 3 years, and we're expecting about 50% to maintain as a core group. And people are welcome to come in and out of that group, as we understand that women are very busy, and this is a particularly busy time for many women, either being pregnant or having young children. Our aim is to update our CCI group every 3 months and for them to provide some high-level feedback about what's happening in our research. So also beyond that, I am connecting with 3 main members from our CCI group, and they're our consumer leaders. And my aim for these consumer leaders is to be really involved in my research journey and to provide regular ongoing feedback. They'll be invited to monthly meetings, to our steering committee meetings, and the aim is to sit down and talk to them about developing some terms of reference, such as meeting frequencies and project expectations. So the aim here is that both the consumer leaders and our CCI group to inform all stages of our research. An example of this is that I've already engaged with some of our consumer members, where our next step of our research is to conduct some semi-structured interviews. And I've asked some of our consumers to review that semi-structured interview guide, and they have, and they've given some wonderful feedback. And this has been really helpful moving forward. So you can see some key considerations for establishing a CCI network. As I said earlier, gatekeepers can be very, very helpful when connecting with community organisations. And this has been really powerful when meeting with people. Relationship building can take time. So working with consumers, it does take time, and sometimes this can be a little bit of a challenge in research, especially when there are deadlines that need to be met. I'm always overwhelmed and very grateful for my participants' generosity. There's a number of participants who always, I say that we'll be remunerating them, and many of them are just happy to participate and be sharing their knowledge and their story, and hoping that it improves healthcare for future generations. And consumers can obviously help keep our research relevant and my research relevant and honest. So when I think about my outcomes from my research and what I really want from it, yes, I'd love to have a PhD, but I also want to improve health outcomes for women. So I'd like to acknowledge my participants, my community organisations, my supervisors, and my funding source. Thank you.
Thank you so much, Rebecca. Terrific. Very interesting talk on a very, very important topic. And I don't think we do it well, to be honest. I think there's so much we still have to learn about consumer and community involvement. So what I can see there is your method and your rigour is going to really help bring that into our science and our ability to do that really well. So thank you very much, because as a PhD student, when you publish on those methodologies, they become almost like seminal, and then people can be guided. Thank you. Thank you, Rebecca. So let me just see if there's any questions for you. Please ask questions of Rebecca if you have any for her. So there's one that's come through, Rebecca. It's hard to do, and so can you tell us more about how you literally embed it right from the outset? That's the question, because often what we do is we actually even conceive of our research question and we know what we're doing, and then we start drawing in consumers, right?
Yeah, correct. So I know ideally it starts at the conception of your research. And so sometimes this can be a little bit tricky, because if you don't have funding to support consumers, but you also want to develop research ideas, it can be a little bit tricky. But getting consumers involved as early as possible in your research, I think, is really fundamental. So ideally it's at the planning stage and the ideas stage, but if that's not possible, then as soon as possible.
Yeah, as soon as possible. I agree. And that's really, really tricky. Like that genuine, consumer and community involvement also takes a lot of time, doesn't it, Rebecca?
Correct. Yeah. So if you've already got established connections, that helps. And again, these things take time. It won't happen for a deadline for a research grant. Like, it might take years where you've known people for a long time and you've established those connections.
That's right. And it also costs money, doesn't it?
Yeah, absolutely.
Do you want to talk about that aspect of it in terms of, a financial commitment?
So I was very lucky, actually. I received a grant through CRE HiPP to be able to bring consumers into my research from the very start. And I can understand how financial costs can be a barrier. At the same time, I think it's really important when you're planning your research to put budget for consumer involvement as early as possible, and to make that as generous as possible as well, because you never know how much you're going to need to draw on your consumers to provide that feedback. So initially, I didn't think these workshops were going to be, or the focus groups were going to be as long or have that many participants, but we had a wonderful response. And so making sure you've got the budget for it is really fundamental.
Fantastic. A question for you, another question for you, Rebecca. Did you experience any challenges with such broad cultural groups while still needing to categorise them, and that's in inverted commas, categorise them all into the same culturally and linguistically diverse label?
Yeah, that's a really good question. So during the workshops, not at all. Like, the women were wonderfully engaged and amazing and respectful, and had they were really, really powerful, and they just loved hearing each other's stories. It was a wonderful sort of vibe that came out of those workshops. As I said, the analysis is only in its early stages, so I'm potentially anticipating some challenges with that. And speaking to one of my participants post-workshop, she did highlight that there's obviously different cultural nuances between cultures, but also within cultures. And she also highlighted that's something really important for me to consider moving forward.
Terrific. And that person also says, fabulous talk. Thank you very much. Another question, how do researchers support CCI, consumer and community involvement, for themselves, like through training, and for the participants? How do you, support that whole system?
That's a really great question. I think it really has to come from an organisational level. So individuals can certainly advocate for it within their research, but I think it really needs to be at a systems level and an organisational level, and really recognise the importance of having CCI and really, as we were saying, embedding it in our research and really valuing it and not making it tokenistic. So,
yeah. Good answer. Good answer. We're putting you on the spot here, Rebecca. Tough. Another question. How did you get around the linguistic challenge on trying to be inclusive but conducting the focus group in English? That's a really good question, actually.
Yeah, that is a great question. We did actually ask that all of our participants were English proficient. And I know that is a shortcoming of the research. However, for, I suppose, practicality, that is one thing that is considered. So during the workshop, that was fine. I don't know, it just worked very well, to tell you the truth.
Oh, yeah. And I mean, it's a really good question, though. And
absolutely.
I guess, a PhD student, there will always be those limitations. But moving forward, we do have to think about how we involve those who don't speak English.
So for my semi-structured interviews, I'm interviewing a number of women, and there is potential room to do some of those interviews in language. So that's certainly something I'm exploring.
That's so good. Well done, and congratulations, Rebecca. That's so impressive. I mean, you literally just have started your PhD, and as I said to the audience, you come with so much experience prior to doing a PhD. So you're sort of the perfect PhD student in that sense. Congratulations, all the very best with your PhD. And thank you so much for being affiliated with CRE HiPP, because we're learning so much from you. So thank you very much.
Thanks, Helen. Thanks for the opportunity.
Great to see you. Bye-bye. Okay, so we're moving along here, which is fabulous. And now I have the absolute pleasure to introduce to you one of our most valued associate investigators. And honestly, this person, Professor Louise Maple-Brown, could be a chief investigator, because your contribution to CRE HiPP, Louise, is outstanding. And I thank you for everything that you do for the Centre of Research Excellence, and also for your collegiality and the fabulous work that you are doing in the Northern Territory. So today I have great pleasure in introducing two of our highly valued and esteemed colleagues that are affiliated with CRE HiPP. We will begin with Professor Louise Maple-Brown. The overall topic is incorporating Indigenous knowledges in diabetes research, the Diabetes Across the Life course, Northern Australian partnership. And Louise will begin, but then Louise will hand over smoothly to, as I said, our very valued colleague, Sian Graham. Sian is of Noongar and Bardi Jawa descent from two different areas in Western Australia, the Balladong Wheatbelt region and One Arm Point in the Kimberley, with very strong connections throughout the Northern Territory and Western Australia. I know Sian has been working with Louise for many, many years, and I know that they've also been working with Jackie Boyle, who's a chief investigator on CRE HiPP. So we are so privileged to have you both here today. I will hand over to Louise, and we look forward to your presentation.
Thank you so much, Helen, for that lovely introduction and for the invitation to speak today. I'd like to start by acknowledging the Larrakia people as the traditional owners of the land where I'm based in Darwin, and pay my respects to their elders, past, present and future. Sian and I are presenting together today. Sian's up in the Torres Strait as we speak, and I'll be starting off the presentation and sharing the slides. We've titled our presentation around walking the path together and incorporating Indigenous knowledge in diabetes research. Sian and I have been on a journey together for over a decade now, and we wrote this paper a couple of years ago in the Lancet Diabetes and Endocrinology around that journey, and together with colleagues in Canada who are walking a similar journey, developing advisory groups in incorporating Indigenous knowledge in diabetes research. So our Diabetes Across the Life Course Northern Australian Partnership is a partnership particularly with communities, and the Aboriginal and Torres Strait Islander Advisory Group is chaired and founded by Sian, who is talking next, and she'll talk a bit more about that group. Other key groups in our partnership are our clinical reference group, as well as our steering committee, which represents our investigators, as well as our partners. This is the vision for our partnership. It's around working in partnership with Aboriginal and Torres Strait Islander people to break the cycle of type 2 diabetes and related conditions. First priority is around prevention and improved management of obesity and diabetes across the life course. Our second priority is around strengthening community engagement in a life course approach to diabetes, with a focus on preconception, pregnancy and youth. And then our third priority is around strengthening the Aboriginal and Torres Strait Islander community-based workforce in diabetes. So this is a schema of our partnership on a page. It's across the life course, as you can see there. And then in the middle, families and communities are centre. And then community engagement and our Aboriginal and Torres Strait Islander Advisory Group, bringing in lived experience, as well as the important element of knowledge translation. And then our projects are lifted over on the right there, and particularly projects around developing knowledge, as well as prevention and implementation. A particular aspect that Sian and I are both very excited and proud of is how we've increased over the years the number of our Aboriginal and Torres Strait Islander staff. We now have 9 Aboriginal and Torres Strait Islander staff out of 30 research staff on our partnership, based across the north, and this has grown over the years, as you can see there. And this has been led really, and Sian has been instrumental in the growth of our Aboriginal and Torres Strait Islander staff members, and the advisory group has really contributed to that as well. So I'd now like to hand over to Sian Graham as chair of our Aboriginal and Torres Strait Islander Advisory Group. Thanks, Sian.
Thanks, Louise. So just a bit of background on the Aboriginal and Torres Strait Islander Advisory Group. So the partnership established governance groups, as Louise mentioned. So we had a clinical reference group, a steering committee and an investigator group. However, there was Aboriginal and Torres Strait Islander investigators and members of each of these governance groups, but no Aboriginal and Torres Strait Islander group representing urban and remote communities. In 2017, we identified a strong need for an advisory group, and we currently have 10 members participating in the advisory group. Members live and work in Darwin and Alice Springs and continue to have strong connections within their communities. Each member comes with a great understanding of health, community-based knowledge and cultural knowledge, and a great understanding. Oh, am I still on?
I can hear you, but your screen's gone to out of slideshow mode.
So Louise was just sharing our screen, hey?
Yep.
Can you see?
Louise, are you right?
Yeah, I don't know what happened. Sorry, hang on, I'll just unshare and share again.
Yes, try that.
Is that back up or?
Yeah, that's good. Just put it into slideshow. Thanks, Louise.
Sorry, I don't know what went on there. I've got 2 going on now. Is that right now? Is it still on?
It's not on slideshow for me.
No, it's not on slideshow for me.
Yeah, that's the same for you, Sian. Yeah.
Yeah.
Okay. Just down there, that button. Yeah, that's it. That's the one.
Do you want me to just keep going?
Yeah,
Sorry about that.
that's okay.
Sorry. So yeah, we currently have 10 Aboriginal and Torres Strait Islander members participating in the advisory group. So members live and work in Darwin and Alice Springs, but still continue to have strong connections within their communities. Each member comes with a great understanding of health, community-based and cultural knowledge, and a great understanding of research. This enables the advisory group to provide advice to researchers and supports the best outcomes when working with Aboriginal and Torres Strait Islander communities. So again, the role of the advisory group. So our main priority is to fill the advisory role between participants, communities, students, and investigators undertaking research in the partnership. So the advisory group works towards providing strategic advice concerning all aspects of the partnership to provide cultural knowledge and advice on the best ways to ensure that research is conducted in a culturally sensitive and culturally appropriate way. So the partnership has come a very long way since the beginning in 2011, where the partnership's focus was more on health systems and clinicians. Yes, this is important, but the missing link was the community level voice. Over time, we have shifted our focus back to communities and are creating a platform where communities can identify their own issues and set their own priorities to inform our future research. It's important that we have Aboriginal and Torres Strait Islander voices and representation to provide our perspective on right ways of working with our communities and our people. It's important that we strive for working in the most culturally appropriate way and ensuring our communities are going to benefit from our research. We need to lead this, especially when our people are at the forefront of this diabetes epidemic. So just shifting space now, I just want to talk to you about a project which is led by Dr. Diana McKay. This project is where we spoke with women about their care and the supports in the health system. So the partnership has implemented a health systems intervention in the Northern Territory and Far North Queensland to improve models of care for women during and after pregnancy complicated by diabetes. Health services in the Northern Territory and members of the partnership's advisory group have identified the need to assess how models of care impact on Aboriginal and Torres Strait Islander women and their families. The project aims to address this gap and identify opportunities for health service improvements to enhance the inclusion of family in the care of a woman with a pregnancy complicated by diabetes. So this project had 4 aims. The first one being to explore the experiences of Aboriginal and Torres Strait Islander women and their families who provide care during and after pregnancy. So the second aim was to understand the role of the family members in supporting Aboriginal and Torres Strait Islander women. The third was to identify health service barriers and enablers impacting on the ability of family members to fulfill their roles in supporting Aboriginal and Torres Strait Islander women. And lastly, the fourth aim was to identify potential improvements to health services to enhance inclusion of family members in the care of Aboriginal and Torres Strait Islander women during and after pregnancy. So as I said before, this project was a qualitative study where we went out to remote communities, sat down with the women and just yarned about their experiences. So previous qualitative research had identified family as being an important support. So we were interested in finding out a bit more about this. So family provided support in multiple ways. So learning from family members who had diabetes, engaging in healthy behaviours such as exercise with family, providing emotional support, and sharing the caring responsibilities of family. Health professionals also identified social media, friends and other formal supports. So shelters, Anglicare, Parents Next, for example. Next slide, please. We also asked participants about the barriers to support. So some barriers were identified were stigma about diabetes can lead women to not wanting their family involved in care. While family members' experiences and knowledge of diabetes can be helpful, the inverse can also be true, where women reported family members being a negative influence if they had a limited understanding of diabetes. Health services also identified barriers. So there was limited knowledge of supports available outside the health service, and a Western model treating a patient as an individual rather than a family or community. So while data collection has been completed in the top end and Central Australia, data collection still needs to be conducted in Far North Queensland. Our next steps are to report back the findings to our communities and finish data collection in Far North Queensland. So this work is going to lead into another project, and this formative work is the key to inform a co-design project with women and communities to reduce diabetes-related risk before, during, and after pregnancy. Thank you.
Thank you so much, Sian and Louise, for your presentation. Really, really insightful and clearly, work that is so important, critically and vitally important. And that's why I'm so proud that you are both associated with CRE HiPP, because if we do not get it right for Aboriginal and Torres Strait Islander women, then we are negligent. And there is no excuse anymore. It's 2022. So thank you so much, Sian, for all that you're doing for community, and Louise for championing that cause as well. We've got time for some questions. So let me just check if the questions are coming through, please. If there's any questions that anyone would like to ask, please do. We did get a comment there, Sian, to just say amazing research. Thank you very much. A lot of people just comment. And another one saying such great work. So everyone agrees. When I first introduced this session, I talked about alliances that we formed through CRE HiPP, because as soon as you sort of get funded for a large body of work, you realise that there's so many things you haven't actually put into the application that are critically important for the success of health in preconception and pregnancy. And one of them was establishing an anti-racism in perinatal practice, because the more that I spoke to midwives here who were Aboriginal midwives and working with Aboriginal women, the more I realised that there are some really serious and grave racist practices that continue today. Is that something that you've been able to, because of your great work with community, Sian, is that something that you've been able to potentially change?
That's a really hard question to answer.
Yeah, I know.
I mean, we had our diabetes summit last week in Alice Springs, and we sort of touched on intergenerational trauma and racism. I think given, everything that's sort of happening around Australia, with Cassius's death and, in Alice Springs, the court case that's going out there, like I was very unsure whether we should actually have these conversations, because it is sensitive and, you don't know how people are going to react to those topics, especially when clinicians are sort of put on the spot. Yeah. So it's very hard to navigate, I think. But we did have, Louise, if you want to jump in, you can at any time. But, we did have a good response to it. And, people were willing to share their experiences and what they face working in the health system. So I think, you know, it was a good introduction to start those conversations, but I think there's a lot of work to be done. And I think we need to have more in-depth conversations about it because, you know, when we think about racism, it's like that's what deters our mob from coming to clinics, you know. And I think it's, you know, educating clinicians about, you know, like a holistic view of health, you know, because our women, there's so many more factors that are going on with them that they can't focus on their health. And then when you go into the health system and then, you know, you're either, you know, have a bad experience, then it's like, oh, you know, they're just running away from the hospital, you know, but it's like, well, we need to look at the whole picture rather than just making assumptions.
Yeah,
sorry,
absolutely.
I hope, did I answer that question?
No, you did, and it was exactly what I wanted you to say, because unfortunately sometimes we feel like there's such great work that's being done. Oh, okay, we don't have to worry about it anymore, and we do, because it's pervasive and it's structural barriers and it's going to take a long time. But we need people like yourself, we need allies, we need everybody working so hard to redress the pervasive racism that exists. So thank you very, very much. Yeah, that was perfect, Sian, and thank you very much, Louise and Sian. There is one more question, and I would like you to consider this one as well before we move to the next speaker. What sort of support has the Aboriginal Reference Group needed? What advice would you have for other researchers?
You need an advisory group for starters, and I think, you know, you need to invest in an advisory group because, I mean, like, you know, we've been going since 2017 and what are we, 2022 now, and it's like, you know, Louise and I and the team, we're now seeing the benefits of this group, you know, and it's like creating that space for, you know, us to sit at the table and be involved in decision making, you know. And I think with research as well, it's like, you know, this is a form of us bringing power back to communities so they can set the priorities, and research is coming from the down up rather than top down.
Love that. I love that, Sian. It's we are at the bottom and the community and those with lived experience at the top. Thank you so much, Louise and Sian, for a really, you know, thought-provoking, a really powerful talk. We've had some brilliant talks and that was amazing. So thank you very, very much for your time and your collegiality.
Thanks
really
for
great.
having us.
Our pleasure. Okay, now I'm moving to our next speaker. We've just been so lucky with all our fabulous speakers today. And I have, again, I'm sort of broken down record, but every single speaker is really special and very important to us at CRE HiPP. And Elizabeth Nakambane, Nakalongo, and Elizabeth did say that she would correct me, so please do correct me if I haven't pronounced your surname correctly, Elizabeth. Again, is a really valued guest today. Elizabeth works with our Chief Investigator, Professor Brian Jack, and she is here today as the Executive Director of LIBO and Mosotho nurse midwife with specialities in healthcare management, nursing education and primary healthcare. Again, you can see the extraordinary expertise and background that comes to this talk today. Elizabeth will talk to us about cultural adaptation of a mobile conversation agent to provide health education to the hard-to-reach adolescent girls and young women in Lesotho. So thank you so much, Elizabeth. Over to you. We can see your slides. You're on mute.
Oh, I'm so sorry. Thank
Thank
you so
you,
much,
Ellen,
Ellen,
Oh, my
for the
pleasure,
introduction.
Elizabeth.
Thank you so much for the introductions. I am Elizabeth Nkabani Nkolongo colleagues, and as Ellen indicated, I am from Lesotho. I'm currently a PhD candidate from the Sefako Mahato University of Health Sciences, the then Medical University of South Africa. Lesotho is in Southern Africa, is a country that is completely landlocked by South Africa. And it is a country with the population of 2 million, of which 70% live in rural areas. English and Sesotho are official languages in Lesotho, and we have the female literacy rate of more than 90%. Briefly, looking at the health indicators, Lesotho has the high HIV incidence and prevalence rates, high maternal mortality ratio of 544 over 100,000 live births, critical human resources for health shortages with the doctor-patient ratio of 1 to 20,000 patients. And my presentation is actually titled Cultural Adaptation of a Mobile Conversational Agent to Provide Health Education to the Hard to Reach Adolescent Girls and Young Women in Lesotho. And this research is actually conducted in collaboration with Boston University and the Northeastern University, as well as my university, the Sefako Mahato University of Health Sciences. And the study aim was to explore the adaptability of the conversational agent called GABI to improve sexual reproductive health for adolescent girls and young women in Lesotho. And my research questions were, what aspects or components of the GABI health information technology should be included or excluded in the cultural adaptation to the Lesotho version of GABI? The second question was, what are the perceptions of the adolescent girls and young women on GABI herself and the health education content that she will be providing education on? The last was about what is the cultural utility of the GABI health informational technology by the adolescent girls and the young women in Lesotho. This is my problem statement and why adolescent girls and young women are a priority population in Lesotho. Is because of the high HIV incidence of 1.5% in females aged 15 to 24 as compared to the 0.5% in males. 73% knowledge gaps in HIV and poor parent-child communication, especially on issues of sex and sexuality, early sex debut, early child marriages, especially in the rural areas. And you can go through that list. And the question would be, why the GABI health information technology? This is the technology that was used in the United States, and it was proved to be effective in providing health education on preconception care. And GABI in the US is able to screen about 100 plus health topics or health risks. And she provides evidence-based content and uses behavioral change techniques. And therefore, the research design and methods. This actually is an exploratory sequential mixed method design. It was employed in this research. However, for the benefit of time, I'll only talk about the first phase of my study, where exploratory qualitative approaches were employed to explore the cultural adaptability or adaptation of GABI health information technology. The study population and setting: adolescent girls and young women aged 18 to 28, accessing healthcare services in the 2 districts in Lesotho, Leribe and Berea, who own the smart Android phones, who are able to speak English, and who gave consent to participate in this study. And therefore, the 2 health centers providing adolescent-friendly healthcare services were selected in each district as the study sites. And therefore, the sampling techniques that were employed in this study, we employed purposive sampling techniques to recruit participants for focus group discussions, as well as key informants from the Ministry of Health. And what actually guided our cultural adaptation? This adaptation was guided by the Barrera and Castro cultural adaptation stages in combination with the PEN3 cultural utility model, because we wanted to situate culture in the center of this study. And therefore, with stage one, it was actually about information gathering and expert advice. And experts were from Northeastern University as program developers and designers, and Boston University, because they implemented this research in the United States of America. And this is where consultative meetings were held with these experts so that we can be able to decide on which aspects of the Gabi health information technology should be included or excluded in the Lesotho version of Gabi. And therefore, the decisions then were made that the Gabi version for Lesotho should be adapted on a mobile phone, and therefore should only have 5 health topics with focus on women's health, since the phone memory was not going to accommodate more than those 5 health topics. And in stage 2, this was the preliminary adaptation, I think, stage. This is where different pictures of Basotho young women were shared with the program developers so that they can initiate processes for designing the Lesotho version of Gabi that will be relatable to adults and girls and young women. And on our right, we can see that picture is of the initial picture for the Lesotho version of Gabi. And this is the version that actually was used when conducting focus group discussions and key informant interviews with the program directors from the Ministry of Health. And the focus was mainly on the naming of the Lesotho version of Gabi, and then also to better adapt her. The focus was also on the physical appearance, hair dress code, the skin tone, hand gestures that she uses, as well as the hairstyle. And therefore, in this cultural adaptation, we actually engaged a young Lesotho artist who actually wrote stories that were promoting engagement with the Lesotho version of Gabi for these adults and girls and young women. We conducted 4 focus group discussions with a total of 33 non-pregnant adults and girls and young women aged 18 to 28. And we conducted 10 key informant interviews with the Ministry of Health program managers from different programs, adults and program, HIV/AIDS, family planning, and sexual reproductive health. And the stories that were developed were actually made into 60 short installments, each with a cliffhanger, so that at least these adults and girls and young women can be attracted by those stories, as they will also get that health information. And we are pleased to indicate that now Nthabi is on the smartphones. And the decision that was made as she was being adapted further was that she should be a nurse, because participants felt that if she was a nurse, then it was going to provide confidence to them that the information that she will be providing will actually be from credible sources, and therefore Nthabi is now a nurse. And this is how nurse midwives dress in Lesotho. And therefore Nthabi provides health education on family planning, nutrition, sexually transmitted infections, HIV, and TB. And I think these are the findings from the focus group discussions and the key informant interviews. And these themes emanated: perceptions on TB, mobile health technology. Majority of the participants felt her appearance is actually relatable to Basotho young women, most importantly about her dress code as a nurse, because the information that she will be sharing will actually be credible and from reliable sources. The second theme was on acceptability and relevance of using hair on TB as a health education and counseling tool. And even here, majority of the participants felt that Ntabi is culturally appropriate, as she was using the language that was non-offensive, especially when addressing issues of sex and sexuality, and therefore they found her to be relatable to Basotho young women. And also the way she was using her hand gestures was appropriate, because as a young woman in Lesotho, you don't have to use like your hand gestures anywhere, especially in a conversation. And another theme that emanated was perceived benefits of using TB. She was found to be non-judgmental, and she had time to explain the health content as compared to healthcare providers who are always in a hurry. And most participants felt that they would rather confide in TB than to healthcare providers. However, there were suggested modifications, especially when it comes to the language. Most participants recommended that the local language should be used by Ntabi, and they felt her accent was too difficult for them to understand. And I think these are the conclusions that we drew from this study. Ntabi was found to be acceptable, culturally appropriate health education provider with the potential to improve women's health. And Ntabi system, although acceptable, modifications were like suggested as I indicated earlier. And therefore, they felt Ntabi provides context-specific, relevant, tailored, and trustworthy information. Her non-judgmental character, ability to maintain confidentiality were considered most important. I wish to thank you for your attention. I'll be guided by your questions. Thank you very much for the invitation, Helen. I feel privileged as an African woman to be in this platform. Thank you.
Oh, thank you very much, Elizabeth. It's our privilege, and that was a fantastic example of how we can work with those with lived experience, women that have needs that our traditional methods are not serving well. And, you know, a patient avatar in that way can potentially, as you showed us there, help women to express themselves in ways that they can't do with a clinician. Congratulations. The work that you are doing, the work that Brian Jack is doing is really pioneering. I mean, this is transformational work. So congratulations, because it's part of a PhD as well, and how seminal and amazing that is for you. Let's see if we have some questions. We've obviously got people saying that it's such a wonderful project. You know, thank you so much, Elizabeth. So great to see the evolution of Gabby and Ntabi in Lesotho. So well done. How do women access the stories? Where on the app are the different topics, health topics?
The story is actually one additional like module that is within like the very same health topics, and adolescent girls will have an option to say, do you want to listen to the story now? And as they converse back further with Ntabi, then Ntabi will be saying, okay, enough with the stories. Do you want to talk about like your health? And yeah, I think that is how the stories have been like included.
Really, really good, really good. And again, you know, such a wonderful project. Another question for you, Elizabeth. Is Ntabi also appropriate or easily adaptable for use in other parts of Southern Africa?
Yes, I think that will be possible. It is interesting, Ellen, because there are already foundations that actually are contacting us because they want us to actually roll it out to other African, Southern African countries. So I think that is possible because she now is available and accessible on mobile phones.
Wow. Yeah. And we know, you know, no matter what level of disadvantage, people do have mobile phones. So it's a way of reaching people, isn't it? And it's so important that we do reach them. And so that's very exciting. Thank you so much, Elizabeth. Really thank you for your time. For everybody, Elizabeth, it's, you know, in the morning for you, and I know that you were up bright and early to be able to join us. There has been one question. I'm going to ask it. Do women answer questions on health like they do with Gabby?
Come again?
Do the women answer questions on health like they do with Gabby?
Yes, they do. They do. They do.
All right. I just wanted to throw that last question in. It came in. But thank you so much, Elizabeth. Thank you for joining us. The privilege was all ours, and we very much look forward to continuing to hear about how it all unfolds for you, especially in terms of your PhD. So congratulations.
Thank you so much. Most welcome.
Okay, bye-bye. And now for our very last speaker, Professor Sharon Bessell. You know, we leave the best to last, but, you know, I loved every single presentation. So this is another keynote speaker. And again, how lucky and honoured are we to have Sharon with us today. I was saying to Sharon when she jumped on before the webinar started that I feel like I've met someone really famous because we're good mates on Twitter, but it was the first time that we actually met each other. So thank you so much, Sharon, for joining us. Sharon is a professor at the Crawford School of Public Policy at the Australian National University. She is the director of the Children's Policy Centre and of the Poverty and Inequality Research Centre. I'm sure many of you know that she co-hosts a Policy Forum podcast, a weekly podcast that's very, very popular. I know it's popular in our house. So Sharon will talk to us about the first 2,000 days and beyond, how health and social inequities impact deleteriously during these formative years. And it's a really lovely book ending with Nisha as a keynote at the beginning around inequities. And now, Sharon, thank you so much. Sharon, over to you.
Helen, thank you so much for the opportunity to be part of this wonderful showcase. They've been amazing presentations, and my gosh, the work that's happening at the centre is just incredible. So I feel so privileged to be here. I'm just going to share my screen, which of course is always the moment of truth. And hopefully everyone can now see the screen. So again, thank you for the opportunity to share some of the work that we're doing at the Children's Policy Centre. Our research at the centre generally focuses on middle childhood, from about 6 or 7 years of age up until around the age of 12. But that work, I think, has important implications, and particularly the work that we're doing around multidimensional child poverty has important implications for health and social inequities in the early years. And so I'm really grateful to be able to share some of our thinking with you today. And I'm just going to fix my screen so I can see it properly. I'm joining you from the south of Canberra, on the beautiful and unceded lands of the Ngunnawal people, and I pay my respects to elders past, present and emerging. So the importance of the first 2,000 days of life is well known, and is certainly well known to everyone in this room or in this virtual room. And it's also reflected in policy, at least policy rhetoric in Australia and globally. During the first 2,000 days, the brain grows rapidly as children learn how to use language, how to display emotions, and to engage with the world around them. Children's physical growth is also incredibly rapid, and systems from the immune to the nervous systems develop very fast. During the first 2,000 days, the human body is better able to adapt than at any other stage in life. Neuroplasticity means the change is profound during this time. And at the same time, the foundations are laid for future health and future well-being. Research now links heart disease, stroke, diabetes, and cancer to pathways that are created in early childhood. There is also evidence that the conditions that lead to obesity, both in children and in adults, are established in the early years. And so the foundations for our future life are created during this critical time. Research from James Heckman's work in the United States to Esping Anderson's work in Europe, and particularly the Scandinavian countries, has demonstrated the benefits to society of investing in the early years. And from a children's rights perspective, every child has the right to an adequate standard of living, to be protected, to be cared for, and to thrive. Australia committed to this and to acting in the best interests of each and every child when we ratified the Convention on the Rights of the Child way back in 1990. And of course, this is what every parent wants for their child to be happy, to be healthy, and to flourish. UNICEF has referred to the first 1,000 days, and we can expand that to the first 2,000 days, as the brain's window of opportunity. Many factors combine to determine whether or not strong foundations are put in place during those early days of life, or those early months and years of life. Mothers' levels of health, nutrition, and stress, social, economic, and environmental context, and family relationships all help to determine whether children thrive. But the reality is that not all children have the same opportunities. Research undertaken at Murdoch Children's Research Centre and elsewhere shows that both cognitive and non-cognitive skill gaps start to emerge between children from advantaged and disadvantaged backgrounds very early in infancy. And those gaps widen across the first 2,000 days, and particularly can be seen by preschool. By school age, children are on developmental trajectories that, while not impossible to shift, begin to significantly shape children's lives. An early start that is shaped by poverty, inequality, discrimination, exclusion, and stigma compromise all that comes later in life. Many of these disadvantages play out not because of the actions or the inactions of parents, but as a result of deep social inequities that create structural barriers to children's development and often happen as a result of unfair or failing systems. The work of the Centre of Excellence in preconception and pregnancy, as we've just heard today, is extraordinary in providing a powerful evidence base and in supporting parents, workplaces, and health systems to have the knowledge they need to be able to support families in preconception, pregnancy, and beyond. What I want to focus particularly on today are the systems and the structures that then make it very difficult for some families to ensure that their children thrive in the first 2,000 days of life, that critical time up to school starting age and beyond. And I particularly want to focus on the ways in which poverty, inequality, and patterns of discrimination and exclusion deleteriously impact children and their families during these critical and formative years. And I'm going to focus particularly on the Australian context here. And so, to begin with a picture of poverty in Australia, 1 in 5 Australian children under the age of 5 is living in poverty. So during those critical 2,000 days, 1 in 5 children are not getting what they need. And here, poverty is defined as less than 50% of median income. And these numbers are based on data that we had before COVID. And so we know that with the current cost of living crisis, this number is likely to get worse. There is nothing inevitable about child poverty. Over the past decade, child income poverty, and this time I'm referring to children up to the age of 15 years rather than 5 years. So for the past decade or so, child poverty has sat at around or just under 18%. But there was a period in our history when child poverty declined considerably. From 1982 to 1986, there was a continual decline in child poverty, both before and after taking account of housing costs. By the late 1990s or the mid-1990s, Australia was regarded internationally as having made very significant progress in reducing child poverty and was favourably compared with the United Kingdom and with the US. We were emerging as a global leader in addressing child poverty through a more generous approach to allowances and tax benefits. And during the Hawke-Keating government, there are a number of reforms, from supplements for low-income families to increased family benefits and rent assistance, that all played a role in reducing child poverty. Child poverty continued to decline through the late 1990s until about 2003. But then it rose sharply from just over 14% in 2003 to just over 18% in 2007. The rise in child poverty during this period resulted largely from lower benefits and conditionality, particularly conditionality placed on sole parents, and that's very often sole mums, and other changes to tax benefits for low-income families. Child poverty rates for households reliant on government benefits rose from 25% in 1993 to 66% in 2017. That's a shocking increase. In 2020, there was a good news story in the midst of a terrible pandemic. Child poverty initially rose as a result of responses to COVID-19, but it then dropped markedly as the government introduced what was called coronavirus supplements that lifted the government benefits that families received. But this good news story, where we saw a dramatic decline in child poverty, quickly turned sour. And as those supplements were removed, child poverty again increased. My colleague here at the Crawford School, Peter Whiteford, pointed out in 2017 that for the past 12 years, governments under 5 different prime ministers, both coalition and Labor, had made explicit decisions to cut assistance to low-income families. Low-income single parents were most severely affected, and welfare conditionality worsened the situation for single parents in particular. So everything that I've described here are policy choices. We choose how much poverty we're prepared to tolerate, accept, or even expect. We choose whether or not we're prepared to allow decisions that let children grow up in poverty during those first 2,000 days of life. And at the moment, we're allowing 1 in 5 Australian children to spend the first 2,000 days in income poverty. I also wanted briefly to say something about inequality in Australia, which is also critical in understanding the social or the health and social determinants of whether children thrive or not. We are a very wealthy country, Based on Credit Suisse's Global Wealth Index, you can see here that we're one of the very few countries globally, marked in the deeper brown colour, that enjoys very, very high levels of wealth. We consistently rank at the top of Credit Suisse's global health ratings. In 2001, we were 4th if we use mean wealth, and we're at the very top of that scale if we use median wealth. Either way, we have much as a country. And yet, that wealth is very unevenly distributed. Based on the excellent work undertaken each year by the University of New South Wales in partnership with ACOS, we see that wealth is very heavily concentrated. People in the highest 20% of the wealth scale hold nearly 2/3 of all the wealth in this country, while those in the lowest 60% hold less than 1/5 of wealth. And for children growing up in the lowest 20%, that tiny dark blue category that you can see, very little of this nation's wealth is available to them. Income is also very unequal in Australia. A child or an adult living in a household in the highest 20% of the income scale has almost 6 times the income of someone in the lowest 20%. And while we're talking about the concentration of wealth, I just wanted to share this slide with you, which is from the Australia Institute, and it simply shows how few of Australia's biggest companies pay tax, and that some of those companies, despite very large profits, pay no tax. And this is occurring in a context of deep budget deficit and fiscal constraint, where the government acknowledges that even good ideas cannot be funded. And discrimination and exclusion play a significant role. Systemic racism continues to create a gap from birth for so many of Australia's First Nations children in particular, despite the strengths of those communities. And 2 decades of stigmatising and shaming people who are reliant on income support, particularly sole parents, has produced patterns of exclusion that have been reinforced by language of lifters and leaners, of hand-ups rather than handouts, that have characterised political narratives of the past decade in particular. And the rise in insecure work, often associated with parts of the gig economy, is creating new patterns of exclusion and precarity for many families. And all of this is creating multidimensional poverty for many children, with deeply damaging implications for their development and for their early experiences of life. In the work that we've been doing at the Children's Policy Centre for several years now, we've developed a multidimensional framework for understanding and responding to child poverty, the More for Children framework. This has 3 dimensions. The first is around material deprivation, and it refers to the money or the material resources that are needed to meet basic needs. It also includes adequate and accessible essential infrastructure. And this is important because many things are not accessible, even if families' incomes rise modestly. Public goods and social infrastructure must be seen as collective, not individual. The second dimension is around opportunity, and this refers to quality child-friendly services and meaningful activities, so the children are able to contribute, or meaningful activities that are able to contribute to children's participation and to their ongoing development. And finally, we have the relational dimension, which refers to the social and economic structures and systems that either foster or fail to foster, and sometimes adequately undermine strong and supportive relationships for children. Not each of these dimensions in and of themselves necessarily indicate poverty, except perhaps the material dimension, which does indicate income poverty. But when they overlap, we see multidimensional poverty, and often very deep poverty. The More for Children framework comes from the rights-based and participatory research that we've undertaken over a number of years with children in middle childhood and with their families. And I wanted to share with you 3 of the stories that has helped to bring the framework to life. So firstly, Mo's story powerfully illustrates how deprivation in the material dimension plays out for a hungry child. Mo was 8 years old when we first met him, so beyond the first 2,000 days, but not by very much. Mo loves his family. He lives in a community where there are lots of nice people that he knows and he feels safe around, and he feels happy when he sees them. He describes his next door neighbours as good people because they sometimes give his family food. Mo is very often hungry. His family struggles to make ends meet. His dad's work is low paid and precarious. His mum works part-time but doesn't earn very much. Mo says that he doesn't tell anyone when he's hungry. He's noticed that his mum is often hungry too, but when she knows that he's hungry, she eats less, and so he stays quiet. This is a loving, caring family that do their best for their children, but we have systems in place that are letting them down. And Mo is carrying a burden that no 8-year-old should have to. Ellie's story highlights deprivation of opportunity. Ellie is 11. She dreams of playing netball or doing dancing lessons, but spends most of her time watching TV or sometimes hanging out in the street near her house. She'd love to go to the beach. She only lives about 35 or 40 minutes away, but she's never been. Ellie lives with her mum, who's a sole parent. Their story is familiar. There was domestic violence, there was a hard decision to leave, and then there was no money. Ellie's mum works, so she isn't there when Ellie gets home from school, but she doesn't earn very much. Ellie says, when we've paid all the bills and stuff, there isn't much money left for anything at all. And so Ellie has come up with a strategy to help her mum. She tries to ask for nothing. She doesn't mention wanting to play netball or to dance. She throws away excursion notes, even if that excursion might take her to the beach, because it might cost too much. And she protects her mum, whom she loves and whom she knows loves her. And the final story I want to share is Amy's story, and this is a mum's story. Amy spoke with joy of her adored 8-year-old child, but she also spoke of being able to give her so little of what she needs, of very often being short of food, of the fear of homelessness, of the insecurity. And Amy said in despair, I sometimes wonder if she would be better off in foster care, but the only thing that stops me is that I know no one can love her the way I love her. This is an incredibly powerful story of how poverty undermines relationships and creates relational deprivation. The relational dimension of the More for Children framework is fundamentally important to children. Our focus here, as I said, is on economic and social structures and systems that foster or fail to foster good relationships for children. This is absolutely not about assessing good or bad parenting. Strong, caring, and loving relationships can act as a buffer to protect children and to support them during those critical years of development. But poverty eats away at those relationships. Amy's story highlights how hard it is for parents to be there for their children when they're under so much pressure that they're running on empty themselves. And this is what we refer to when we talk about relational deprivation. Mo's, Ellie's, and Amy's stories matter in themselves, and they reveal a great deal about children's lives and about their families' lives. But these individual stories, and children's stories particularly, their views and their experiences also matter collectively in letting us better understand what the world is like from the perspective of children. And as we hear more and more of children's stories, experiences, and ideas, we can identify consistent themes, and we can start to develop a child's standpoint. The idea of a standpoint is that people who are part of a particular social group have unique knowledge because of that social position. Children have particular knowledge because of their age and their place in society. And we can go further. Different groups of children have different knowledge of the world because of their age and their place within their societies. and within their communities. Children who experience hardship as a result of poverty or disadvantage have unique knowledge that is not shared by those with very different life experiences. The Moore framework reflects a child's standpoint, or aims to do so, by drawing on our research with hundreds of children and their families over time. And while the Moore framework has been built from research with children in middle childhood, I think it also has deep significance for children during their first 2,000 days. Deprivation in the material dimension means income poverty or very low income. And today, that almost certainly means housing insecurity. And it's likely to mean food insecurity, hunger, and inadequate nutrition, which is so critical to children for both their physical and their cognitive development during those critical early days. Deprivation in the opportunity dimension is likely to mean that there are structural barriers to accessing services, which may be physical, for example, around distance or lack of transport, or it may be attitudinal, resulting from the behaviours of those who are providing services. And we've heard powerfully about some of that today. And it's likely to mean that children have insufficient opportunity to play. It's likely to mean that they are socially excluded even before they reach school, and are more likely to experience learning and educational opportunities that are not child-friendly or are characterised by inequity or lack of resources. And deprivation in the relational dimension means parents are under enormous pressure, like Amy. These pressures are often created and exacerbated by inequality and by the punitive policies and unchild-friendly forms of welfare conditionality that we've seen in recent years. They're also exacerbated by precarious and insecure work that pays no heed to children's rights, interests, or needs. And so how do we turn all of this around? I'll leave you with one key message and 5 steps that we can take. So the key message is that we need to be genuinely child inclusive or child-centred. In the work that we've done at the Children's Policy Centre, we've differentiated between these 2 approaches. Child inclusive policies and practices are those that do not position children as the primary focus, but ensure that children's needs, rights, and interests are a primary focus, and children are identified as key stakeholders in all that we do. A child-centred approach is an approach to policy or to practice that places children's needs, human rights, and interests as the primary focus. We may not always be child-centred, and sometimes that may not be appropriate, but we should always be child-inclusive, and currently we're not. And so, to leave you with 5 rather large but critically important and very possible steps, we need child rights impact statements of all policies, not just those that seem to apply to children. We need to be child-centred or at least child-inclusive in budgeting. And now there is a remarkable opportunity for this as Australia begins on what may well be a long journey towards a wellbeing approach to budgeting and government policy. We need to be child-friendly in our planning, creating communities that are child-inclusive, safe and welcoming so that young children and their families can thrive. In terms of expanding opportunities for children who are living in contexts of poverty or disadvantage, policies and funding models around education, including early childhood education and care, are critical. Educational equity and child-centred education are essential, and this needs to begin in the early years and continue throughout. And we need a more just approach to income support. Remember the drivers of poverty that I spoke about earlier, which are very much around the very low levels of income support that many families receive. And we may need a more just and equitable approach to our tax and transfer system. Remember that graph that I showed with so many of those very profitable corporations posting often hundreds of millions of dollars in profit, paying no taxes. As I said, these are 5 very big steps, and at first sight, they may not appear to be centrally related to the early years, but they are steps that are needed to ensure that children's lives are not damaged and in some cases destroyed by health and social inequities during the first 2,000 days and beyond. We can make these changes in Australia to ensure that all children have a fair go. And these are changes that I would suggest that we need to make urgently. Thank you so much.
Thank you. Thank you so much, Sharon. Oh my goodness. Powerful talks the whole way through this showcase. You know, this is my passion as a developmental psychologist. I can't thank you enough. I can't thank you for all your advocacy, for all your work. It was very depressing, actually. It was like we started with Nisha's talk, and that was depressing too. It was a difficult conversation, and then we're having another difficult conversation because it is appalling that we are in a wealthy country and that we are not doing right by our children who are living in poverty. I mean, it's a disgrace. So it's a national disgrace. So thank you, Sharon, for all you're doing, you know, from your, you know, the ground level in terms of the research, but also at that much higher level, because we know that you're, you know, in the ears of policymakers and wanting to make a difference for our next generation. If we don't get it right for children, pack it up. There's nothing left for us. We are not deserved of that. So we've got questions coming through, so we'll take a few, and thank you again. How beneficial are short-term increases in family benefits on child poverty and related child outcomes if they are taken away again shortly after? Like, for instance, some of the benefits with COVID were then taken away.
Look, I think any increase in benefits is a bonus for families, is a good thing for families, even if they're very short term. There was quite a lot of research done around the impact of those coronavirus supplements, including by a colleague here at the ANU, Elise Klein. And it was remarkable what people spent that money on, you know, on dental care, on fixing things that needed to be fixed, on having better levels of nutrition, and on things that really mattered. And so that made a difference in the short term. And we can't underestimate those short-term benefits. But of course, suddenly being able to go to the dentist or to buy your medication or to give your child decent food and then having that removed is in some ways more painful. And there is a deep injustice, I think, about offering people something or providing people with a glimmer of hope and then removing it. And I think what we saw from those short-term increases is that we can make phenomenal differences to people's lives, phenomenal differences to children's lives, if we choose to do so.
Yeah, that's right. It's the choice, isn't it? Policies that lift children out of poverty are surely cost effective in terms of health and long-term education and employment for children and impacting future generations. We all know it. It's a no-brainer. Why do you think policymakers are so reluctant to support these policies and systems? You know, why are they so reluctant to decrease child poverty and deprivation? It makes no sense, does it?
I wish I knew the answer, Helen. I know that.
I didn't ask the question.
The evidence, as you say, is so incredibly strong. And you know, we see that from, you know, from the health impacts to the employment income impacts in the future. If we are only interested in future human capital or economic outcomes, then investing in children is such an important thing. And of course, we might also be concerned about children's rights and well-being, and then it becomes even more important. I think part of this is that it's often framed, or these debates are often framed in terms of, well, if we want to lift children out of poverty, one way of doing that we know is to increase income support for people who are on government benefits, or it's to make changes around minimum wage to ensure that families have more. And these arguments are often presented as a zero sum. It means we have to increase taxes and others do worse, or we lose something for some to gain. And I think part of the real problem has been that naming and shaming of people who are doing it tough over the past 10 or 15 years. And so we've othered people. We've somehow seen them as being different and less worthy. And I think all of that comes together to mean that these issues have not been a policy priority, because we've been able to see child poverty as something that happens to other people who perhaps have created their own problems.
Yeah.
And I think that's what we have to work on shifting first.
Yeah, it's that individual blame, isn't it? And the
That's
stigma,
right.
which is so appalling. There's a question here about, you know, when we want to address this pervasive disadvantage and poverty, we tend to work in siloed approaches across sectors. How do we break down those silos? Like, how do we, when we're, you know, a medical person and see, you know, a child with living with poverty come into the emergency department all the time, and then of course in community services there might be child protection issues, and then of course the early childhood educator in the first 2,000 days could tell any politician this child will, you know, have poor educational, health, social outcomes for the rest of their life. They can pick it, you know, in literally the first year of kindergarten. How do we start to combine, you know, to do things together?
I mean, this is a conversation that we have been having for so long about how we start to break down those silos. Helen, I think the work that you're doing at the centre is critical to that. You know, I think the more conversations we have about these things are so incredibly important. I do think perhaps to bring a little bit of optimism to the conversation, you know, one of the things that we've seen from the federal government, particularly into the lead up to the budget a couple of weeks ago, was discussion about what a wellbeing approach to a budget might be. And I think this does give us an opportunity to really shift things, because if we start to put wellbeing at the centre, we're looking at different indicators. We're not just looking at economic indicators in terms of how we're performing as a country, but then we also need to start to think differently about how we achieve wellbeing, about how we think about policy. And so this really opens up a way for us to think differently about funding models, to think differently about how we can collaborate across those different silos. And so I think we have got a window of opportunity to use that idea of well-being to do things quite differently and to build interdisciplinary approaches, cross-government agency approaches. But Helen, I also wanted to pick up on one comment that you made about child protection issues. And one of the things that we see in the research that we do is very often poverty is misunderstood or misrecognised as neglect. Yes. And if you look at the formal definition of neglect that we have, it's almost the same as poverty. And I think this is also something that we really need to address. That when we see this playing out, we don't turn to kind of statutory child protection approaches, but we say, how can we support this family to care for the child that they love? Understanding that the driver here is poverty and all that sits around that, not neglect.
And I'm so glad you said that, Sharon, because that's exactly what's happening. The default is child protection, and I just was describing the different sectors and how they, yes, you know, have. But you're absolutely right. No parent wants their child to be suffering in that way or not to be thriving. It's about how we remove the individual blame, the stigma, and support them. Because if a mum is drug addicted, if a mum has come out of prison, if a parent, you know, is in the child protection terms negligent, there's always a reason, and it's a systemic reason, not an individual reason, you know. So if we take it all the way back, we know intergenerationally that person may also have been let down by the system and, you know, grew up with pervasive disadvantage. So thank you for mentioning that, because it's such a good point. Look, we could go on forever and ever. There's congratulations, such a powerful presentation. Thank you, Sharon. Wow, I've got tears underneath the tissues. So thank you very much for completing our story today on health equity. We cannot, in the Centre of Research Excellence in Health and in Preconception and Pregnancy, have a narrow view about health, because as we've seen today and as we know through our Centre of Research Excellence, the problems that women face, and when we do focus on women in our CRE, although we do have our LGBTIQA+ alliance, are chronic and they are wicked. And we can't have, you know, the one lens and the one size fits all approach. So I'm really proud of CRE HiPP because we are broadening our lens. We are tackling some of the most difficult topics. We're not ignoring them. And thank you, Sharon, for contributing to our understanding that actually that child was born into the world. That child was part of a conception and pregnancy. We cannot disentangle the two. You know, if we just think of, okay, well, we're talking about children now, and now we'll focus on pregnant mums, we get it all wrong, don't we? Because it's intergenerational. And so that smooth, you know, the first 2,000 days really makes very, very good sense for supporting health and wellbeing of the parents and also the next generation children. So on that note, I'm going to wrap it up. I couldn't have asked for a better showcase. It was outstanding. It gets better every single year. And that's a testament to the funding from the National Health and Medical Research Council. It really does show that these schemes work and that they really do provide a platform that can leverage funding. You know, it's $2.5 million, but literally snowball and create an empire of capacity building and knowledge generation and translation and these discussions that we had today. So thank you once again to every single one of our very important and valued presenters. Thank you to everyone that joined us live. I know there's many that have registered that will be watching the recording because this is how important this showcase was. Have a good day. If you're not into the evening yet, for those of you who are on Melbourne time, Australian time, have a wonderful evening and thank you very, very much. Bye, everyone.